The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Dr. Dennis Birnbaum, and this is Cancer Update, short walk through a long journey. The phone number here at KAAM, 770 AM on your dial is 972-445-0770. The toll-free number is 877-272-5226. And if you wish to reach us at Texas Hematology Oncology, I know this is a lot of numbers we're spewing out right now. The toll-free number there is 469-453-5500. We have a lot of topics to cover today, some recent articles that have come out that are quite interesting. And one of the most interesting things that has come out that will be affecting the election coming up is an article out of Value-Based Cancer Care that talks about the indirect cost of metastatic breast cancer, which are quite substantial. And I wanted the public to be aware of this because the cost of cancer is going up dramatically. And depending on who you vote for and how you look at it, it's going to affect how you will be able to deal with the cost of cancer today. In general, breast cancer is prevalent among women of working age. A new study came out that compared the costs related to the low productivity of women with breast cancer. In a study of 432 patients with metastatic, meaning breast cancer that had spread, had a 41-day short-term disability leave and $6,166 of associated costs, compared with 25 disability days and a $3,690 of associated costs of 1,552 patients compared with early-stage breast cancer that were not metastatic, meaning early treatment, early detection has a profound effect on the overall costs and the work stability of the woman in the workforce. Cancer treatments are diversified. Many of them are treated with hormonal therapy if you're estrogen or ER/PR positive. For those patients who are HER2 positive, they need to go on to a drug called Herceptin, which I'm afraid to say is quite expensive and costly to the patient. It can be given either on a weekly basis, or if you give it at the 6 milligram per kilo, it can be given every 3 weeks. Because of these costs, it needs to be affirmed exactly what is going to be the overall cost of your cancer, whether it be breast cancer or colon cancer or any type of cancer in the high economic burden associated with cancer in general. Another thing that was brought out that was shown is the increased incidence of thromboembolic disease, meaning blood clots, deep vein thrombosis, pulmonary emboli, creates a high economic burden associated with the thromboembolic phenomena in patients with cancer. Study done at the Duke University at the 2002 European Society for Medical Oncology showed that the development of venous thromboembolic phenomena, VTE, costs about $100,000 per person and had a significant economic burden in terms of health care expenditure. VTE, or venous thromboembolic phenomenon development, is associated with a significant economic burden in terms of healthcare expenditures. The cumulative rate of VTE, seen most predominantly in prostate and breast cancer patients, almost doubled at 12 months in these patients. There was an enormous high rate. The index date was defined as the first day of chemotherapy after being diagnosed with cancer. The incidence of venous thromboembolic phenomena was greater than 25% in patients who were on systemic chemotherapy, and it affected the outcome of the patient. The development is associated with a significant economic burden. The data from a large health insurance database revealed that the rate of embolic phenomena in patients with prostate or breast cancer almost doubled at 12 months. And the annual adjusted cost, this is very important, the annual adjusted cost 12 months after initiating chemotherapy increased from approximately $56,000 in patients without VTE to approximately $91,000 in patients who had venous thromboembolic phenomena. So you say to yourself, well, how do I prevent it? Well, your doctor needs to be made aware of it. You need to be aware that your incidence increases, especially for those with breast cancer and prostate cancer. You need to be checked with Dopplers of the lower extremities, with CTAs of the heart and lung, in order to evaluate whether or not you have a deep vein thrombosis of the lower extremity or a pulmonary emboli of the lung. And these are factors that are very, very important as part of the total cost in dealing with cancer treatment. Another article that has come up and was approached to our staff about 2 weeks ago was the difference in therapeutic approach to colorectal cancer in the young population versus the elderly population. When I was at MD Anderson, age was never a criteria for treating a patient. Usually the quality of life, the overall performance status of the patient were the criteria that we use. I had mentioned before on this program of a patient that had a parotid gland tumor, was 96 years old, went through Erbitux and radiation therapy, and unfortunately recently died, but died at age 102. He had gone through his therapy at age 96 for over 3.5-4 months, went into complete remission, and really he traveled, he played cards, he was with his friends, he lived at home, had his family take care of him. So age was really not a criteria. The article here talks about, in comparison with younger patients, elderly patients with colorectal cancer usually are undertreated, mainly because of their age, not because of their tumor type or any comorbidities. Now, when we talk about comorbidities, remember, a patient will come to you and they've been diagnosed as having, let's say, colorectal cancer, and they're of the older age, and they also have diabetes, and they also have emphysema, and they may have previous heart disease, or they're being treated for hypertension. Well, these are comorbidities. They have other diseases that go along with their colorectal cancer. Elderly patients have a significantly shorter tumor survival time, particularly because of being undertreated. The article goes on to say that they think that this is wrong. They think that the elderly patient who comes in with the same type of diagnosis as the younger patient in their 40s or 50s, the elderly patient in their 60s or 70s, they both have colorectal cancer. They both have similar histological type, that there is no reason unless there is a comorbidity reason or unless there is a very poor performance status of the elderly patient, that they should be treated any differently without the same type of treatment modality and same type of protocol as the younger population. They've shown this repeatedly to be effective. They've shown it to have as good, if not better, head-to-head survival rates and response rates, as well as having tolerance to the treatment. They don't get any more less nauseated. They don't get any more less side effects with diarrhea or constipation than other patients at a younger age. Another article that recently came out, and this was from the Value-Based Cancer Care Journal, talked about the continuation of Avastin. We've talked about Avastin many times, how it was first developed in metastatic colorectal cancer, metastatic meaning spread from point A to point B. It then went effective and was used in breast cancer and lung cancer, non-squamous cell lung cancer, non-small cell lung cancer, in people with metastatic renal cell, meaning kidney cancer. The article talks about a significant improvement in outcome of patients with metastatic colorectal cancer when they have a continuation of treatment with Avastin beyond disease progression in patients with metastatic colorectal cancer, as reported at the 2012 European Society of Medical Oncology. They show that in giving Avastin with either the FOLFIRI protocol, which is 5-FU irinotecan, or the FOLFOX protocol, which is 5-FU and oxaliplatinum, or a combination of both of those with Avastin, that the survival shows that there was a 35% reduction in the risk of progression, as reported by the medical director of oncology at the University Hospital in Italy. This is now the second randomized trial investigating the impact of Avastin in metastatic colorectal cancer, which is one of the most common cancers in the United States today, showing that its effect is necessary in the treatment of metastatic colorectal cancer. Another article is Personalized Cancer Care Affordable. As you're aware, there are many new practices coming out in the United States. A lot of family practitioners and internists that are going into the boutique type of medical practice for a set sum of money. They handle patients' medical care with home visits and specialized hospital visits. They have found that the trends that work against controlling the cost of medical care, including an aging population, a dependency ratio, and a lack of morbidity or comorbidities. The number of patients who are frail or who have bad health for a longer time is increasing, leading to a larger cost burden. The majority of increasing healthcare costs in cancer and in oncology results mostly from pricing. Some suggest that personalized medicine will lead to affordable care, but this is not happening today. The healthcare pipeline, which can be considered a silo for oncology, in which a large amount of agents and technology are at the top, translational medicine is at the center, and the burden of the disease, the complications of the disease, the side effects of the disease that you have make it go towards the bottom of the group and make it impossible to make it a more personalized type of practice. Because of the enormous side effects associated with systemic chemotherapy and concomitant chemotherapy and radiation therapy, we are not able to more personalize or make oncology a more, let's say, boutique type of practice. In doing so, this has led to the increased costs associated with the various types of cancers and whether or not certain cancers should be treated. One of the things that has come out in recent months has been on most of your TV channels lately is the underappreciated cause of cancer deaths, disparity in treatments. There's been a disparity based on race, socioeconomic factors, and other non-clinical factors affect the outcome of patients with cancer. 39,000 projected deaths for breast cancer in the United States in 2012. An estimated 6,000 of those deaths may be preventable with appropriate therapy. The breast cancer mortality rate is 22.4 per 100,000 white women and 31.6 per 100,000 of the black population, and the gap continues to widen. Other disparities in breast cancer care include the type of insurance, the high poverty rate, and the less education. Should it be this way? I don't know how to answer that. I know that, for example, if you don't live in Dallas County and you live outside of Dallas County, let's say in Collin County, then you cannot benefit from the use of Parkland Hospital and their cancer program for some women. African American women with breast cancer are less likely to receive definitive therapy, including chemotherapy, hormonal therapy, radiation therapy, or surgery from a localized disease compared with the white population. This was an article by Dr. Freeman in Cancer in 2011. This article came out of the Breast Cancer Symposium. There are disparities in care no matter how you define the population in the care. Sometimes there is more emphasis on getting a new fourth-line chemotherapy agent to market than in providing adequate and decent care to people who simply just need the basic parameters of care. Paying the cost of treatment disparity is estimated that more than 230,000 American women will be diagnosed with breast cancer in 2012, and more than 39,000 will die from it. If all women with breast cancer received optimal therapy, up to 6,000 of these women, of these deaths would be averted. Dr. Brawley reiterated that a substantial proportion of patients with cancer do not receive care that is in accordance with established guidelines. These patients are not getting the inexpensive treatments that are universally accepted, such as lumpectomy with radiation therapy and even adjuvant chemotherapy. At the same time, we are spending more and more on expensive treatments. We are talking about the latest $8,000 a month drug for a third-line treatment of advanced disease that prolongs survival by only 3 months, while we are missing the point. If we simply did the things we currently know and applied our current technology that we currently have, such as mammogram screening, we have the ability to improve survival and increase the quality of life and save lives. This is one of the things that is present today in our economic structure in the treatment of cancer, as it is becoming more and more difficult to adequately treat patients based on socioeconomic basis. Again, from this same journal, we have talked about this before. Another article goes back and talks about the anti-cancer effect of metformin. If you remember, metformin is a drug used in diabetes. has been shown to be very effective in cholangiocarcinoma, carcinoma of the biliary tract, has been shown to be effective in use in pancreatic cancer. And now they're showing that women with diabetes taking metformin have a significantly lower risk of breast cancer, an association that appears to grow stronger with increasing duration of follow-up results of a recent meta-analysis. Overall, the people who used metformin had a 17% lower risk of breast cancer compared with women who did not use the drug, including diabetic women who were taking other hypoglycemic agents. Diabetic women using metformin had a 17% lower risk of breast cancer compared to the non-users. The risk reduction increased to 25% in those taking the drug for greater than 3 years, and 32% when follow-up started before 1997. Obesity and diabetes are risk factors for breast cancer. So again, ladies, when you go to your doctor, talk to them about this. Talk to them about if you have problems with diabetes or problems with weight. Additional evidence has shown that metformin has a protective effect against breast cancer and has undergone enormous amount of observational studies. And this is probably about the 5th week that we've talked about it. So it's something that we need to look into. We have a call waiting. Let's answer this. Hello, this is Dr. Berenbaum.
Hey, Dr. B. Good afternoon.
Good afternoon. You have a question for us?
Well, I do. I've been listening to your show. It might not necessarily be totally related, but if you will allow me to interject a somewhat of a non sequitur to what you're talking about, but I respect your opinion. Listen to your show every Friday afternoon. So I'm a relatively young, I suspect 59, extremely healthy in terms of all blood results and exams and all of that stuff. Non-smoker, non-drinker, in the gym 5 days a week. I've always had good checkups every year. And recently I just got a PSA test for my prostate. Always been normal, but for the last 6 months went from 2.8 over another month, 3.1, 4 months, maybe 3.8. And then for my complete physical for my work, it came out 4.4. So I think that is over the threshold. Am I right?
Yes.
So with that in mind, they recommended I go see a urologist, at which point I did, and sort of just said, let's wait on it 90 days, or we could come back and do another blood test. So my question for you is, in the last year, for seemingly what I believe a fairly healthy 59-year-old, and I'm not sure if that has anything to do with being healthy or not, but how unusual is that rise? How alarmed should I be? And what would you do if you were me?
Okay. There are two elements of population that we're dealing with here. One is in your age group, going up from age, let's say 55, 60 up to age 70, and then the younger population. The things that you have to worry about is prostatitis, prostatism, urinary tract infections, problems with ejaculation, problems with infection. If none of these elements are there, then the first thing I would do is to make sure that somebody who is well trained does a DRE, a digital rectal examination.
Dr. B, I'm sorry to interrupt, but did you mean like pain associated with those listed things?
Pain, discomfort, if there is any blood associated with it, if there's any fever, discomfort within any of those acts, whether it be sexually, urination, even when you defecate, if you're having some pain in the anterior pelvic region, then I would be a little bit alarmed by this. I'd want it checked out. because you've gone from a normal value precipitously to an abnormal value. And if you've gone this route without any signs or symptoms, without any criteria, and you're a pretty healthy person and you work out and you watch yourself closely, then I would be a little bit concerned about this. If I get another PSA and it is even higher, then number one, I want to do a digital rectal exam. Now remember, do not do a PSA test after a digital rectal exam for at least 4 weeks, because if I do a digital rectal examination on somebody right now, they're going to get a false elevation of their PSA. So if you're going to do the PSA test, then have your doctor do a digital rectal exam. And the other tests I would do would probably be a prostatic sonogram. It's a special probe that they do, and they do a sonogram of the prostatic organ, which will measure the size of the gland. It will also pick up any lumps and bumps or nodularity. Now, if this continues to go up, it used to be there were 3 tests you could do. One was the CEA, the carcinoembryonic antigen. That's kind of gone by the wayside, but it still is a reflection of adenocarcinoma, which is the primary histological type prostate. The second is the prostatic acid phosphatase, which some people still do in conjunction with the PSA. And then there's definitely the PSA. In my case, I probably do at least 2, if not all 3 of the tests, number one, if I see a progressive increase in the PSA value. I would definitely get another PSA before doing a DRE examination and a prostatic ultrasound, both of which can give you false elevations of your PSA. And if these are either abnormal, let's go down 2 different paths here. Let's say the DRE and the prostatic exam is negative. There is nothing abnormal on it at all. However, your next PSA has gone from 4.4, let's say it's 4.8 or 4.9 or 5. It's higher than what it was. I think personally at your age that you need for a urologist probably to do a biopsy, because you don't want to wait till it becomes out of hand and that it becomes larger and is in a metastatic area.
I think being the cautious person that I am, the doctor's already scheduled for next Wednesday a biopsy is what he said he wants to do. So, I mean, I'm okay with that, but I certainly want to be proactive, correct?
I would definitely be proactive, because in this type of disease, early detection is virtually curable. Quality of life is better. With the early detection, you're able to eliminate the problem in its entirety, long-term survival. As I usually say to a friend of mine, you'll probably die from something else long before you'll die from your prostate cancer.
Well, what's interesting, he told me, and then I will let you go because I certainly do appreciate that feedback, is that in the last couple of years I was put on a medication called Cymbalta, which is just for anxieties. That's what it was for, not depression.
Right.
But that certainly sort of pushed back the ability to have any sort of ejaculation or sex, and there could be that buildup. And he certainly brought that up as a caveat, I suspect, right?
I'm not aware that that Cymbalta can cause a false elevation of the PSA, but I will say I think you're right in doing what you're going to do next week. I think you're right in getting the biopsy,
right,
if for no other reason, peace of mind.
All right. Dr. B, as always, I thank you so much, and I think really certainly appreciate what you do for us every Friday.
My pleasure. Thanks for calling.
Thank you, sir.
You bet. All right. Hello, can I help you? Hello? Are you there? Hello? All right. That caller disappeared. Another thing that has come up recently in dealing with cancer and facing cancer is that of couples creating new relationships, nurturing existing partnerships after a cancer diagnosis presents an enormous amount of challenges. One of the most rewarding things that I have seen over the years is the relationships between individuals that has just increased their closeness and their ability with each other. Wait, we got a caller. Hello?
Hi, Dr. Birnbaum. My name is Judy. I've been listening to your show today.
What could I do? You have any questions?
Well, I noticed earlier in your broadcast you had brought up breast cancer, and my mother's currently undergoing treatment, and I feel like it's really taking a toll on her, and I want to know how much you would think, is enough for her, because I'm really worried about her health. When is enough when it comes to treatment?
Good question. I get confronted with this. I had this question brought to me today by a patient who is presently at another hospital having undergone radiation therapy. And the question continually comes up from many non-oncology people, both nurses and doctors, when they face the encounter, when is enough? When should a patient go to hospice? When should you stop treatment? Because a lot of times you have the family who absolutely refuses to want to give up. They feel that they owe it to their mother or their father or their loved one, that they were always told that, they want to go to the nth degree. In the case of somebody that is newly undergoing treatment and is not used to the chemotherapy, if they are on IV systemic chemotherapy, the problem that you run into is that these are new drugs. You try and be as open with them as possible. You must take the time to explain all the side effects of the drugs, all the problems that are going to arise with nausea and vomiting. If they're on something like Folfox for colorectal cancer, that the oxaliplatinum is going to cause neuropathy. They're going to get numbness in their lips and their tongue. They're going to get peripheral neuropathy in their fingertips and their feet. With the 5-FU, majority of people get this profound diarrhea. In the same respect, some may even get constipation. So you've got to be up there and prepared to tell them not only what the side effects are, but how to eliminate the side effects and what drugs to have them have on hold in order to take these. Now, if they're early in their treatment and they've got a disease that is really treatable, the hard part is to convince them, in spite of all the side effects, in spite of all the things that they have heard, in spite of losing their hair, their eyebrows, that things will get better, that they have a disease that is treatable, and you try your best to encourage them to stay with the treatment and to go through the treatment. Now, that's at one end of the spectrum. Let's go to the totally opposite end of the spectrum, which is where the biggest debate comes on, and that is the patient who has been under treatment for a long time. And you've run the gamut of just about every type of protocol you can give them. You've even sent them to maybe down to MD Anderson or here in Dallas to Mary Crowley to see about second-line therapy, phase 2 therapies. What other options are there? And the family still wants to continue. Those are the patients that are most difficult. And for me as an oncologist, I run into the problems of the hospital not wanting to go further. They want to put the patient in hospice, or they want to put the patient in a long-term care facility, and you run into the problem with the family not agreeing. And it's just an ongoing relationship. You can't just abandon the patient and be rude to the family, but you must take the time to explain to them that, A, we've gone through all the treatments, even if you need to bring out protocols and show them. B, that we've sent the case off to MD Anderson, or we sent the case down to Mary Crowley, or we sent it over to the medical school, and they have nothing else to offer, and that going into hospice for comfort care is really the best way to go at the present time. And even I have a few patients that are young. They're in their 40s or early 50s that are terminal, and they've gone through the gamut of every type of chemotherapy, radiation therapy, our concomitant protocol there is, but it's basically that enough is enough, that you need to stop and just let them be as comfortable as possible and keep them as comfortable as possible with whatever anti-nausea medication they need or pain medication that they may need.
Well, that's very insightful. I also have another question that's related to that, since my mother is very terminal in her stage, and my grandmother also passed away from it. Having a family history of breast cancer, I was wondering, when should I first get checked, how often, and do you recommend getting genetic testing?
Yes, yes, and yes. Right now, I would get tested. If you have a family history, and we've discussed this many times on the radio show, if you fall into the cancer family syndrome, and we'll go over that again, what it is. If you, let's just say, for example, you have a brother and a sister. You take your mother, and you take your mother's parents and her brothers and sisters. You take your father and your father's parents and his brothers and sisters, and you add up all of those people together. And let's just say, for sake of argument, that totals 20 people. And out of that 20 people, 7 have had some form of cancer: skin cancer, leukemia, breast cancer, ovarian cancer, prostate cancer, colon cancer. But 7 out of 20, that's greater than 33 1/3%. Anything over 20% means that you and your brother and sister are at an increased rate or risk factor for developing cancer. So you fall into the cancer family syndrome. That number doubles if it is your mother, your mother or your aunt, first generation, that has cancer. Then that number, if it was 33 1/3%, doubles up to 60% chance that you or your brother or sister are at an increased risk. I would then recommend, instead of waiting, in your case, to age 40 or 50 to get a mammogram, I would start with a baseline now. Make sure that you have a yearly pap smear. I would also go and make sure that you both your brothers and sisters get a BRCA genetic testing. Your mother should have one, and you should have one as well. And if the BRCA is positive, there are some studies out there that say that you should probably go ahead and have a prophylactic mastectomy done, even though you have not been diagnosed with cancer, because your risk factors are so high of developing cancer in a very short period of time. But you and your family, regardless of the genetic testing, because you fall into the cancer family syndrome, should be watched carefully and closely, and your family doctor should be aware. Somebody should tell him, look, I fall into the cancer family syndrome. I need to be watched closer. I need to make sure that I have my mammograms, my pap smears, my chest x-ray, and if necessary, certain blood tests need to be done. And probably every other year, serial tumor markers should also be done.
Well, I'm in the Dallas area. Where would you recommend I go to get genetic testing?
Well, we do it in our office. Most medical schools do it. We can send you to have this done. It's a very simple blood test that is sent out, and we would have the results back in probably a week to 10 days.
Well, thank you very much, Dr. Birnbaum. You've really answered my questions.
Thank you for calling.
Bye.
Bye-bye. excuse me. So we're going to take a break for a moment. I hope you all come back. This is Cancer Update, a short walk through a long journey. The number here is 972-445-0770.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Dr. Dennis Berenbaum, hematologist oncologist. This is Cancer Update, a short walk through a long journey. The phone number here at KAAM 770 AM on your dial is 972-445-0770. And the toll-free number is 877-272-5226. We do have a caller. Let me take it now. Hello, this is Dr. Berenbaum.
Oh, hi, Dr. Berenbaum. How are you?
I'm fine, thank you.
Well, my name's Jackie McMurray, and I just wanted to tell you how much I enjoy your show and that what a good hospital Parkland Hospital is, because I had this awesome Dr. Brooks. I don't know if you've ever heard of him, but I had breast cancer, and he told me to, take both of them off. He was trying to help me because it was going to go to the other one, and I've had the chemotherapy and radiation. Now I take Tetrazole. And
okay.
I've tried to do everything they said, and that chemo, though, it does make you hurt. Isn't that right, Dr. Berenbaum?
You said the chemo makes you hurt?
It does.
It can.
Tetrazole, it kind of makes my bones hurt.
Yes, ma'am, that is very true.
But I just wanted to let you know what a good hospital, Parkland Hospital. I know a lot of people complain about it, but I got excellent service there, and I had a double mastectomy, and I'm going on 5 years now. And,
well, that's excellent. I'm glad you're doing well.
But here's what my point. Do I just need to just keep going forward now? I think maybe after 5 years, I've been taking it because I had so much cancer in my system. You probably already understand that,
Well, most of the studies on
they didn't want me to worry about it. They just say what this means is you need to take this for 5 years.
Right. That's what most of the studies on anti-estrogen medication, be it tamoxifen or letrozole or any of them, is for a 5-year period of time.
I took Arimidex for a while.
Right.
My cancer is estrogen positive.
Okay.
I've learned so much too. And I've done what they said, but I know you have to do what you have to take care of yourself too. They can only do so much. What you were saying earlier, you have to help yourself. Don't you, Dr. Berenbaum, have to help yourself?
Well, you need to make sure that you follow your doctor's instructions. Make sure you stay on a strong nutritional program. I'm a very big advocate myself on encouraging our patients to exercise. I think that exercise improves the immune system. And other than that, I think you need to have a good mental foundation that just go on with life. Don't let the cancer run your life.
That's what they told me. This one doctor, when he was taking that port out,
Mm-hmm.
He said, you've had a big kick in the gut, but just go on. In other words, just don't look back and don't dwell on having cancer, just like you're saying. He said nobody goes with unscathed. Something.
Well, you've taken a long step. You've beaten the cancer, and don't let the cancer control you.
So you think 5 years out is pretty in remission now?
I think that's excellent. I think if you've had all your testing done.
I went all the time to Parkland. I practically lived up there. And they would, once it would be like every 2 weeks, every 3 weeks, every month, every 3 months. And now it's just once a year. Isn't that wonderful?
I think that's outstanding. I think you've done real well. And like I said before, I would just go on with your life. You probably need to be seen maybe once every couple years to get a checkup. And don't miss your checkups, but just go on with your life now.
That's right, because, at first I was scared, and there is a fear when you have cancer, but I've just, you just have to deal with it head on, is what I think.
Well, I appreciate you calling. I think you're a great example and very encouraging, and you're right. Parkland has an excellent program. It's an excellent teaching hospital, and it sounds like you did very well.
My doctor that did my surgery was a Harvard graduate, so I can't complain. So God bless you, Dr. Birnbaum.
Well, thank you for calling in. You have a nice day.
Thank you.
Bye-bye. Well, it's calls like that make going into the field of oncology extremely rewarding and what just makes things feel a lot better. One of the things that you find over the years is facing cancer as a couple, creating relationships and nurturing existing partnerships after a cancer diagnosis can present enormous challenges, and that open communication and mutual respect can build strong connections and lasting intimacy. Just because somebody has cancer does not mean that their relationships and their feelings for one another are becoming less. What I have noticed personally in at least 85 to 90% of the cases is how much it makes their relationship stronger, how much it solidifies the feeling that they have. What I have found more than anything else is children of cancer patients who weren't very close with their parents as they got older just seem to gravitate back to their mother or father who is sick, and it's like they just want to be part of their life now. They want to share those moments with them. There is no denying that cancer diagnosis changes everything. The impact of the diagnosis can be felt in every area of a person's life, from the physical to the psychological to the spiritual to the emotional. Cancer can affect not only how the patient feels, but also how they feel about themselves, which can have an impact on current and future intimate relationships with partners or spouses or significant others. One of the main problems that we see in dealing with cancer, and I see it in women, but obviously I see it more in men who have cancer, the macho attitude. They do not want to be a burden. They do not want to put this on somebody else. They want to try and take care of it themselves. And this is exactly the wrong thing to do for two reasons. And I've seen this over the years in many of the support groups that Tina has put together, how the families have come together, how this macho attitude really is unnecessary, because over a period of time they find that it is rewarding not only to the caregiver, to the wife or the spouse or the significant other or the child or even the nephew or niece who is taking care of the cancer patient, but the patient themselves gets a sense of earnestness with themselves and with the family member that they want to share it with them. and they become closer over a period of time. Many factors contribute to a patient's ability to maintain or create fulfilling, intimate relationships in the wake of cancer diagnosis, including others' reactions to the situation and the patient's own sense of self-worth. Many, like I said before, many times the cancer patient feels that they are a burden. They are more concerned about the cost to the family in time, in energy, and especially in money. And really, in the long term, they find out that this doesn't even matter, that the family is more concerned about the well-being of the cancer patient and their quality of life than they are about anything else. Though the aspect of the cancer journey can present challenges, striving for honest, meaningful communication can help ensure that cancer doesn't shut the door on intimacy and love. I have found in the years that I have been dealing with cancer patients, one of the things that they're concerned about is during the period of time that they're on either radiation therapy or chemotherapy, their sex drive is diminished. A lot of times additional creams and ointments may be necessary. Even medication may be necessary. But yet, in spite of it all, going through this together, I have seen a sense of intimacy that was never there before. I've been told by patients that their relationship with their loved one has gotten better through this journey through cancer, through this journey through therapy, and going to support groups with their loved one. So if you have a family member that has cancer, take them to the support groups. Go with them. Be with them. I realize at times you're not able to because of your work schedule, or you have other responsibilities either with children or your own work schedule, or it just doesn't fit into the time that you can go there. But if you're able to, your presence as a caregiver, as a partner, as one who is sharing the moment with the patient who has cancer is far more important than you'll ever realize. And in years to come, you'll see that it is something that adds to your relationship. The big bridge is to get across, is to start communicating with each other. Talk about your feelings. Talk about what is bothering you. If you're the caregiver, let the patient who is being treated know that you're there for them, that through the chemotherapy, through the radiation therapy, communicate. Tell me what's wrong. Tell me what you need. Tell me where you hurt. And if you're the patient, don't be afraid to discuss what your feelings are and what your problems are. Find out if both of you are ready to resume intimacy and sexuality. Intimacy and feeling nurtured and close to your partner should be there at all times. The idea of wanting to help and take care of somebody that is going through radiation therapy or chemotherapy, or if you've got head and neck cancer and you're getting concomitant chemo with radiation therapy, is tough. It is really tough. Thank God I personally have never had to go through it, but I've seen a multitude of patients in 35 years who have had to go through it. And it is not something that is easy to do. And to have somebody there who is always there to help you in your times of need, when you're down, when you can't eat, when you're having a difficulty time in swallowing, having that person there is more important than you'll ever know. I have a patient that lost his wife about 6-7 years ago, and when he came down with head and neck cancer, out of nowhere, both his son and daughter showed up, and he was, when he and I talked in private, he was beside himself, that he did not think that they cared that much about him, that they lived in other cities, but yet now when he needed their help and did not expect it, they showed up. So cancer has a way of bringing people together without even asking for it. It can be there. There are many resources out there for you to communicate with. There's the Center for Intimacy After Cancer Therapy. They have a website and a phone number. The American Cancer Society, Sexuality for the Woman with Cancer, and Sexuality for the Man with Cancer. It's an 800 number, 1-800-227-2345. There is an enormous amount of books out there that deal with intimacy and caregiving, from both aspects of cancer, both the patient's point of view and the caregiver. One is Love is a Journey, Couples Facing Cancer. It's by Jan Latona, Latona. The other is Loving Ain't Over for Women with Cancer, and Saving Your Sex Life, a Guide for Men with Prostate Cancer. And the last one is Intimacy After Cancer, a Women's Guide by Sally Kidd and Dana Rowlett. All of these are books that you should be involved in and know about. This has been a great day. The weather is beautiful. I hope everybody has prayers for the people on the East Coast. That was devastating, just unbelievable. I want you all to have a great weekend. We're going to have a guest here next weekend, and it's been a great day with you. This is Cancer Update, a short walk through a long journey. Please join us next Friday at 2 o'clock in the afternoon, Central Time, and the number here is 972-445-0770. Have a nice weekend, and God bless you all.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700, and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.